Thank you, everyone. Thank you to Uncle Alan Madden for welcoming us. And I would like also to acknowledge the Gadigal people, the traditional custodians of this land, and pay my respects to the elders, both past and present. I would also like to thank you all for participating in our forum today. I hope the discussions do generate some thought-provoking ideas for you to take away. So I'll start the day by setting the scene for why we're all here today, and it's obviously for young people. Young people are important. Young people are our future. Young people are also a potent, conflicting mix of bravado and uncertainty, innocence and cynicism, self-expression and peer conformity. They're also particularly vulnerable to poverty, violence, and risk-taking behaviour. It's our job to work with young people and protect them as much as possible while supporting their development into mature adults. From a policy and public health perspective at the Ministry, we approach the issue of young people's use of alcohol and other drugs from a harm minimisation perspective. We also want to support the development of healthy lifestyles to avoid chronic disease and deaths in adulthood as a result of the behaviours that were established when people were young. We recognise that young people are a diverse group. Minimising the harmful impacts of risky behaviours among young people demands a range of responses. For example, some young people experience problems in the short term relating to their alcohol and other drug use, while others are at significant risk of substance-related harm in the future. Some young people have a history of mental health problems, as well as with alcohol and other drug use, and others have experienced trauma or social disadvantage from a young age. We need to cater to this range of needs and backgrounds. Before going further, I do want to discuss some of the patterns of use for alcohol and other drugs in young people. Looking first at young people and alcohol in New South Wales. The Chief Health Officer's report on alcohol notes that more than 1 in 3 students aged 12 to 17 in 2014 had never had an alcoholic drink. And this is double the proportion in 2005, which was 17%. So there's some progress. Students from major cities were more likely to have never had a drink than those from regional or remote areas. Also in 2014, just under half of students aged 12 to 17 reported drinking alcohol in the last 12 months. Of these, about 1 in 20 reported drinking 4 or more drinks in a day in the last 7 days, compared with 1 in 10 in 2005. So that's more progress. Almost 1 in 5 students aged 12 to 17 who reported drinking in the last 12 months stated that they intended to get drunk most times or every time they drank alcohol. This is similar to 2011. For students aged 12 to 17 who drank in the last 12 months, there was no variation across socioeconomic groups in the intent to get drunk most or every time. So I think you can agree there are very clear successes, but there's also still much work to be done in relation to alcohol. We'll see why in a moment. Turning to young people and other drugs, the National Drug Strategy Household Survey in 2016 released its detailed findings, which show that the average age at which people aged 14 or older used their first illicit drug has fluctuated around 19 years since 1995, the age of 19. Since 1995, age of initiation has increased for methamphetamine, cocaine, hallucinogens, and heroin. The age of initiation is youngest for cannabis and oldest for cocaine. Users tend to be older when they first misuse pharmaceutical drugs compared with illicit drugs. 25 years for pharmaceutical drugs compared with around 19 years for other illicit drugs. And that's an important point we'll return to. Apart from the very well-known use patterns for the most common illicit drugs, as a health system, we do place a lot of emphasis on monitoring emerging trends for novel, emerging and unknown substances. For example, we've recently been examining the evidence around the use and harms with nitrous oxide canisters. Similarly, GHB, gamma hydroxybutyrate, and something that you may not have seen too much of, these are e-liquids. And the reason I put up this particular picture is twofold. One, this is marketing to children. And the other thing is the flavour. The thing that distinguishes e-liquids from cigarettes is particularly the addition of flavourings and colourings, which in fact may be harmful, especially when inhaled at high temperatures, something that most flavourings and colourings were never intended to do. This is important to understand. And I just want to share with you one recent case in New South Wales relating to these tablets, which I'll refer to from now on as the Blue Superman tablets. In early October, the Ministry received a report from Newcastle of the Blue Superman tablets being sold as ecstasy, resulting in emergency presentations to Calvary Mater and John Hunter hospitals. Overall, there were 11 presentations within a 2-day period in people aged 18 to 28 years. 8 of these people arrived by ambulance, and 6 were either triage category 1 or 2, meaning immediately or imminently life-threatening, due to reduced or loss of consciousness. There were further sporadic presentations over the following 1 to 2 weeks, all in people living close to Newcastle. This is one of many incidents that occurs across New South Wales. In this instance, we supported a state response, including in particular the rapid analysis of the tablets by the State Forensic Laboratory. Now I'll let you think about what the substance might have been, and we'll come back to that at the end of the talk. We've discussed patterns of use. Now, it's not so much the use of substances that's the issue, it's the harms that result from the use of substances that we're particularly concerned about. And there's many examples of the evidence of harm. Obvious ones from a health system point of view relate to emergency department presentations, and in this case I'm showing you the recent data for alcohol or methamphetamine use in New South Wales in 16 to 24-year-olds, where you can see that over that 8-year period there has been a slow, steady reduction in the number of people presenting to emergency departments with alcohol issues, but that's actually still 3,000 presentations a year. However, there has been a substantial increase in the number of people presenting to emergency departments from methamphetamine use, up to around 1,000 presentations. The thing is, there's still a 3-fold difference in the number of presentations for alcohol compared to methamphetamine. In terms of the most serious harms, obviously deaths, I think it's really important to understand the patterns and to reflect on them so we can better understand how the health system can prevent and respond to the harms associated with other substances. So this is the most recent data showing the age-specific death rates for drug-induced deaths in Australia, the whole of Australia, not just New South Wales. And I must emphasise that this only looks at directly drug-induced deaths. It doesn't look at all the attributable deaths that might be associated with alcohol or other drugs. And in this instance, it's only examining the other drugs. It's not even examining alcohol alone. That's completely separate. So it's just the other substances we're looking at here. And you can see that the pattern of deaths in Australia shows a marked peak in men at around 35 to 39 years. And in women, the peak is actually around 45 to 49 years. So in middle life, for the most part. And some good news is that in young people, 15 to 19, 20 to 24, the deaths are relatively low compared to those older age groups. Comparing to what we saw in 1999, this is the same picture that you saw just previously. The bar graph is the same, showing you the current picture, and the green line is what was that picture in 1999 for men, and the purple line is that picture in 1999 for women. And you can see that there's been a very substantial change in the pattern of deaths across Australia, specifically directly related to drugs. And so in men, the peak has moved from that 25-year-old age group up to the 35 to 39-year-old. In women, the peak was also at a very young age, so between 20 and 35, and it's now shifted to 45 to 49. However, the overall number of deaths is still approximately the same. So the important point here is the habits and patterns of substance use are still established very early in young people, and it's these habits that will lead to harms and potentially early death, even if not when they're a young person, within 20, 15, 10 years in midlife. So if the patterns of death have changed so much, has the pattern of substance use leading to death changed? I'll have a look. Here you can see the various drug classes that were responsible for those deaths, those directly drug-induced deaths, across Australia over the last 10 years. And you can see that opioids is the top blue line, and it has always been the top line. And you can see the pattern in 1998 and 1999 related to particularly heroin at that time, with a sharp decrease but a steady increase again since 2005. The next most important drug class is depressants, which includes particularly the group of benzodiazepines. And then the next, currently, there's a tie between antidepressants, which are prescription drugs, and the stimulants, which is mostly methamphetamine. So on that picture, the light blue purple line that has shown an increase since about 2011 is stimulants, methamphetamine largely, which is now tied for third place with the antidepressants. But you hear a lot about methamphetamine. You don't hear anything about the antidepressants. Similarly, opioids and the other depressants have always been the top two, and you don't hear as much about them as you hear about methamphetamine. It's very important to monitor the emerging trends, and I don't dispute that stimulants are an important cause. I just wanted to show you the overall context of all those drugs, and again, emphasising alcohol's not even here on the picture. So in terms of, instead of looking at drug classes, because that's quite a big category, if you look at the drug types present for those people who died over that period in Australia, we can see, I think, some very important patterns that we need to pay attention to. So think for yourself, if you don't know, think what you think is the commonest particular drug type present that leads to death, directly drug-induced death in Australia. It's benzodiazepines. Alprazolam, diazepam, oxazepam, clonazepam. These are all prescription drugs. The next one is other opioids, particularly oxycodone, codeine. These are prescription opioids. You'll see that, in fact, in 1999, oxycodone, codeine, and were number one, the prescription opiates. Even though that era is thought of as the heroin era, the prescription opiates were the number one cause of death. Now they're number two behind benzodiazepines. The third drugs, the psychostimulants, principally methamphetamine, there has been a substantial increase in the number of deaths. Fourth is heroin. You can see even in 1999, it wasn't the top two. Next, other antidepressants, all of the prescription antidepressants. Then the other synthetic narcotics, fentanyl, tramadol, pethidine. Again, there has been a substantial increase in the number of deaths related to these particular drugs, or prescription opioids. So that brings me back to the blue Superman tablet. So I hope you've been thinking what you thought that was. It was alprazolam, benzodiazepines. I'll just quickly touch on our service response. I know that you're going to have a much more detailed discussion about the various service responses for young people. I think it's important to emphasise that we understand that it's very important to think about what it takes to care for and work with young people effectively to meet their needs. Young people want to have a say in the decisions about their health. They want us to respect their privacy. They don't want to be treated like a child. And in some cases, many cases perhaps, they don't want their parents to know. And we need to understand and respect that. There's also evidence that services don't cater well for young people with mental and substance use disorders. There's fear of confidentiality breaches, lack of trust in the service provider, and embarrassment in discussing personal issues, a lack of awareness and knowledge about services and how to access them, and a lack of referral to treatment when they do come into contact with services. So what is the government doing? The New South Wales Government recently announced the drug package, which particularly includes $24 million to help more young people over a period of 4 years. We recognise that young people are important, and that's why the New South Wales Government increased funding by $75 million over 4 years to tackle the harms associated with drug use in our communities, and that includes a specific $24 million for young people. Some highlights include the $16 million for detoxification and treatment services for young people, $15 million to expand substance use and pregnancy services, $8 million to increase residential rehab for women and parents with dependent children, and $8 million for the Early Intervention Innovation Fund that will help build the evidence base for early intervention models to support people at risk with a particular focus on young people using drugs. As you know, individuals who experience multiple and complex needs are often frequent users of emergency services, and without the right network of care in place, we're missing opportunities to direct more people into treatment, including young people. In addition to funding services on the ground, the package seeks to develop high-impact research and evaluation that is directly relevant to whole-of-government responses to reduce the harm from alcohol and other drug use. This has the potential to transform current policy and practice in New South Wales. Finally, I'd just like to acknowledge that service providers and clinicians are integral to our treatment success, and we rely on the people who are out delivering services to our young people on a daily basis. The question of what else we can do in this space is really something I would like you all to consider today. We cannot continue to deliver services in exactly the same way. The drugs keep changing. The children are different, young people are different, and the world that we live in is evolving. There certainly was no way of buying any drug you wanted over the internet 20 years ago. We need innovation, new ideas and new models, and we need to intervene early to change the trajectory of young people's lives. And the presentations today really encapsulate these ideas. We're very lucky to have Dr. Yifra Kamina, Professor of Psychiatry and Pediatrics at the Alcohol Research Center and Injury Prevention Center at the University of Connecticut Health Center in the US to discuss continuity of care. Dr. Bronwyn Milne from the Sydney Children's Hospital at Westmead is going to highlight the importance of early intervention and making the most of every opportunity in a paediatric setting. Dr. Natasha Perry will provide her perspectives on international innovative treatment approaches for young people using alcohol and other drugs that she gained as part of her recent Churchill Fellowship. And importantly, we're going to hear from a range of local service providers, Kirkton Road, Weave Youth and Community Services, and ACON, to talk about the risk groups and the opportunities and challenges in each of their spaces. And I'm very pleased to say that we'll be hearing from Bianca Schmidt, who will talk to us about her experiences and provide a young person's perspective as part of the panel discussion at the end of the day. I hope you will actively participate in today's forum, and I sincerely hope you enjoy the day. Thank you.